Hello everyone, my name's Katie. I'm one of the Foundation Year 3 doctor in Milton Keynes Hospital. I'm also a clinical educator at the University of Buckingham. I've got my colleague Sophie in Crewe campus. Sophie, would you like to introduce?
Yes, so my name's Dr. Sophie MacArthur and I'm a clinical educator up in the Crewe campus of Buckingham Medical School. So I spend part of my week as a clinical educator teaching the first and second year medical students, and then the other part of my week I work at Southport Hospital up in the northwest of the country.
Perfect. So today we're going to talk about what is the typical day of the junior doctor. But I've been told that we've got a mixture of audience today, some final year medical students, some potentially international student. So I've included slides on the overview of the NHS, timeline of getting into medicine and medical career pathway in UK before we start talking about the typical day of a junior doctor. Okay, and then we'll talk about some on-call cases, referrals, and at the end, we'll give you some top tips to survive your foundation training. All right, and you'll have a chance to ask questions at the end. I hope you enjoy it. So this is for the benefit of international students or people who were not familiar with the UK healthcare system. So NHS is the National Health Service. It's a government-funded medical healthcare service for everyone living in the UK. It's totally free, and it was founded in 1948. So the way the NHS runs in different levels. So it starts with primary care. So what that involves is a community care. So your general practitioner, community district nurses, opticians, and dentists. If the patient is not if the patient needs more specialized care, then they will be referred to hospital, which involve hospital specialist doctor like cardiologists, endocrinologists, and then physiotherapy team and dietitian team. Not every hospital is a tertiary care. So tertiary care is more highly specialized care where a bit more niche surgery, such as like neurosurgery or open heart surgery may be performed there. So at the moment, I'm working in Milton Keynes Hospital, which is secondary care. If a patient in Milton Keynes Hospital needs a neurosurgery input or they need a surgery of their brain, then they might be sent to Oxford, which is the tertiary center of this region. Okay, I've been told that there's a quaternary care as well. So it's more highly specialized. It's the extension of the tertiary care. It's very, very highly specialized and it's not very common. But the main common theme is primary, secondary, and tertiary care. Okay. So now getting into medicine. So you can either get into medicine through undergraduate route or a postgraduate route. So the first two route is A-levels or IBs, International Baccalaureate, is the equivalent of A-levels. And then depending on the grades, you get into medical school. That is the undergraduate way of getting into medical school. So how I got into medical school was I did my GCSE A-levels and then I did undergraduate degree, biomedical science, and then I applied for medicine. So I'm a postgraduate student. So it doesn't matter how you apply. You can either apply straight through high school or through a different degree. I know some of my friends who's got pharmacy or dentistry degree before they also get into a medical school. So it's just a different route. Sophie, how are you an undergrad or postgrad?
So I was undergrad, so I did my A-levels and then I applied to a few different medical schools and then went to Liverpool. But I think the experience is probably very similar, and I wouldn't say that one is advantageous over the other. It's just
I
maybe
agree.
what suits you
Yeah,
at the time.
absolutely. Yeah. So this is the typical medical training pathway in the UK. So medical school is around 4 to 6 years. After you graduate from UK medical school, then you have to do a mandatory foundation program, which is 2-year training. So foundation year 1 and foundation year 2. So during foundation year 1, you'll be under provisional GMC license. And after you've completed your foundation year 1, then you'll be given a full registration for GMC. This is your medical license, okay? And after that, you can either take a year out, which I'm doing at the moment. I'm a foundation year 3. I'm doing some teaching in medical school. So I work in medical school from Monday to Wednesday, and then I work in hospital on Thursday, Friday. I know some of my colleagues are taking time out to travel or do some research. Because I graduated in a year of COVID in 2020, a lot of my colleagues and my friends from my year took foundation year 3 to have some time off the on-call rota and just enjoy foundation year through and build their portfolio. Or if you want to start your training straight away from foundation year 2, you can do that as well. So specialty training, you could either do GP, general practitioner, which is 3 years training after your 2 years foundation training. You do further 3 years, and then you'll get license for general practitioner. If you want to go down a specialty route of medical or surgery, you'll have to do further 5 to 8 years to become a consultant. And that depends on what specialty you choose. There's some variation. Sophie, would you like to add anything?
Just in case people aren't quite sure of what a general practitioner is, so that would be like the family doctor who looks after people more in the community, so not particularly based as much in the hospital, comparing that to a consultant who would run clinics but also might work more based in the hospital. But once you get to that level, there's a little bit more flexibility in terms of building your career and building your job and doing what suits you and what particular areas interest you. So there's lots of different options. Kind of being a doctor is just one part of it, but then all the variation of being a doctor is huge. And I think sometimes, certainly when I was applying, I didn't really realise that. I thought, okay, consultant in the hospital, GP in the community, but actually, if we link it to the foundation year 3, you could be doing, as a consultant, you could be doing some teaching as well, some research in different areas. So there's a lot of variety kind of within the run. I think there's a lot more diversification of roles kind of more recently as well, which is nice to be able to do lots of different things and get lots of experience.
Yeah, absolutely. So yeah, it depends on what you want to do, and then you can choose that pathway. So this is a role of a junior doctor. So mainly we'll start the ward round in the morning. After that, you do the jobs from the ward round with the consultant. So the common jobs of a junior doctor is writing discharge summaries for patients who are being discharged, or requesting scans, which is chest X-ray or CT or MRI scan, prescribing, or getting advice from another specialty, and doing on-call shifts. So we'll talk more about it in a bit. So the ward round is normally when the consultant do the ward round, you're a junior doctor, then you'll be writing the notes on what the consultant, conversation between a consultant and a patient. And these notes are legal documents. Say if the patient is unwell or they're not satisfied with the care they receive, they could then, complain or sue someone, and the notes that you've written will be used as a legal document. So it's very, very important for you to do it properly. So normally how I do it is before the ward round, we normally do notes preparation. That is to learn about a patient that you're going to see with the consultant and potentially present to a consultant during the ward round. Some consultants like to be presented, so they want to know who they're seeing. So you just learn a quick short summary of a patient. For example, this is Mrs. L, she's 65 years old, presented with hip pain. She's got past medical history of osteoarthritis. These are her blood results. She's got hips x-ray done here. This is her drug. She's been seen by orthopedics, and that's the plan. So just a quick, nice summary of the patient's journey so far since admission, okay? And during the ward round, make sure to date and time, put consultant name and award name. Observations is mainly when you're seeing the patient, what's the patient like? So their heart rate, their oxygen sats, temperature. So there's a new score that we use in hospital, and we tend to use it, say news score 0, observation stable. And if you do any examination, make sure you put like chest clear or abdomen soft and tender. Always put an impression. Impression is what you think is the diagnosis of the patient. So if you're not sure, always ask the consultant what their impression, or if you're reviewing a patient yourself, always put an impression as well. Okay, and when the consultant give you a plan, always clarify if you're not sure what to do. There's no point of you guessing and then, you know, making a mistake. Then just ask and clarify to avoid any misunderstanding. Another hand over to the nurse in charge. I always like to do that because we're all looking after that one patient. A nurse is looking after, doctors are looking after. And it's nice to just tell the nurse that, oh, we've just seen this patient and we're going to do this. Could you do urine sample for this patient or something? So the nurse is also in the loop and they know what's happening, okay? And after you finish the ward round, say you've seen 30 patients today and you've got a big job list. What I mean by rank them in order is if there's a very sick patient, you would want to prioritize the jobs for that patient rather than leaving it at the end, and then patient will deteriorate in the evening. So make sure you rank the job in order of and prioritize sick patients and do the job list. Sophie, would you like to add anything?
So I think particularly when you're mentioning about prioritizing your job list, that's obviously really an important part of the role, and how that might link with some of the guys who've joined today. When we interview, or any medical skills interview, that would probably be a skill that we would be looking for to see how well students can react to that. So you might get a question where there's a scenario and you've got to think of different responses, and then you've got to order them in terms of importance. That's trying to kind of draw on that skill as to something that's very important when you're working in the hospital, because if you prioritize the wrong patient or spend time doing the wrong task, as you said, other patients might deteriorate. So it's about being very organized and planning your time effectively. So I think that's a really helpful thing to think about.
Perfect. So this is an example of my ward round entry. I'm not saying this is the right way to do it and you should do it this way. It's just an example. You know, everyone has their own way of writing their entry. The main thing is to make the notes clear so whoever read it knows exactly what's happening and knows a plan. So I've put a date and a time. Consultant ward round, Dr. Potter. MAU is the location of the patient. 76 years old. The little symbol next to 76 means female. and triangle is the diagnosis that, presenting complaint that they came in, so left hip pain. Background is kind of their past medical history, or how they presented, like history of presenting complaint. So she had a fall 1 week ago, presented with the left hip pain, and now she can't really walk well. Bloods, NAD mean nothing significant in her bloods. Her X-ray of left hip is nil acute bony injury, so no fracture. So new 0, observation stable. And past medical history, she's got GORD, which is acid reflux, and chronic back pain, and type 2 diabetes. So I've briefly just mentioned that patients lying in bed, comfortable at rest, which means patients not in pain, they're just lying comfortable. And then their pain is very well controlled with analgesia. If not, then we might have to increase the analgesia. And consultant has explained that there's X-ray show nothing, so just mobilize with physio and occupational therapy team, but no other concern. Okay, so if in the plan, analgesia, just continue with analgesia, physio OT team. And if physio fails, which means if she cannot mobilize well with physio, then we might have to do MRI hip, which means sometimes we can miss a fracture in X-ray. X-ray is good for very, very obvious fracture, but if it's a very, very tiny fracture, then you can miss it on X-ray. Then MRI is a really, really good investigation for it. Okay. So now discharge summary. So discharge summary is a letter you write from hospital to general practitioner in community. So GP will be in community looking after this patient, and they know this patient very well. And then when they come to the hospital, you write a discharge summary back to their GP, so their GP knows what happened in the hospital. It shouldn't be a massive long essay. It should be something that's have a good summary with key findings. So this patient presented with the fall, and we did an X-ray, we found a fracture, we did this procedure, this is the diagnosis, and now her pain is very well controlled. She's going to have community physio care team, and anything specific that you want GP to chase. For example, can you repeat the blood test for this patient in 3 weeks' time to make sure her hemoglobin is stable, or something like that. If you need something for GP to do, make sure you highlight that. And if you change any medication, or if you stop or start new medication, always make sure to put it, and always mention the reason. You stopped this because patient had a bad reaction, or you started it because patient presented with new high blood pressure. So it's always nice to know why have you stopped or started this new medication. Okay. And yeah, safety net, as in if anything, say if the patient, deteriorate, please refer back to me or something like that. Okay. Sophie, any tips on discharge summary?
Yeah, so I think with this one, thinking about the skills that are needed for this is all about communication, isn't it? So good communication between different healthcare professionals. So this is, as you said, between the hospital and the GP, and sometimes we'll have communication face to face, on the phone, and this is obviously an example of written communication. So you've got to be kind of really succinct, really clear in what is the message that you're trying to get across about that patient, because otherwise, lots of doctors still see lots of different patients and it can become really confusing. And again, linking it to thinking about, what makes a good doctor, what the values of a good doctor. This is one of the reasons why communication skills are something that are kind of very sought after and we look for, because this is how it's going to be applicable. One of the ways that be applicable in real life.
Yes, agree. So Nexus Prescription, as a junior doctor, you'll be prescribing lots and lots of medication. Okay, so always ask a senior, if you're not sure about patient medication dose or names or what type of medication, always ask, how long do you want this, like for example, antibiotics. So do you want it as an IV or oral, or is it 3 days or 5 days? Always be specific and prescribe. You're going to prescribe it under your name, and you're going to sign under your name. So it's your responsibility. So make sure it's accurate. Okay. If you're on call and you've been asked to review a patient and you need to prescribe, then always refer to trust guidelines with, say, antibiotics. Always make sure to check patient allergies, and say if you see a patient in A&E and patient's quite confused and they can't give you a history of what they're taking, what their regular medications are, you can also ask next of kin, which is their like family members or sometimes their carers, to check the information on the prescription. So I don't know if you've heard of blister packs, which is the picture on the right bottom, where the some of the patient can't really take medication on, they don't remember what to take on their own. So this blister pack is made up by a pharmacist and is literally everything in one box. So they just take the whole pack in either morning or afternoon, and everything is sorted for them. Anything to add, Sophie? Sorry, the light's gone off.
No, I think it's fine. I think you just got to think about how it might be very difficult for patients who are taking lots of different medications. They might have memory problems. So something as simple as a blister pack can make it a lot easier. And obviously, as a doctor, part of your role is writing that prescription, but it's also really important to think about the compliance of the patient with that prescription. So if you give them a medication or a drug that they don't want to take, or they don't understand, or they find side effects unpleasant, if they're not taking it, then it's a waste of time us prescribing it. So again, that good kind of rapport with the patient and being able to listen to them and see how they're taking medication is something that maybe we don't always think about, but I think it's really important to consider as well.
Yeah, absolutely. So medications like flucloxacillin, you have to take 4 times a day. Some people absolutely hate taking tablets. So giving them tablet to take 4 times a day, they might not be compliant. Then the wound's not healing, or they have cellulitis, then you have to check why they're not taking it. What could we do? Then they might need like IV or different type of medication or different type of antibiotics. Okay. Next is radiology request. So that's like scan and request for the scan. So always make sure to put in patient's age, gender, why they came into hospital, and what's the reason for the scan. So normally radiologists, they can't see the patient, so they're only reading your requests and trying to work out what they need to look in the scan, if that makes sense. So I'm just going to go through a few exercises with you on how to request appropriately. So example 1 is, say you've been asked to request a MRI hip, and the first request, 75 female, admitted with the 4 hip pain. Is this a neck or femur fracture? Is this a good request? What do you think? If you don't mind just typing in a chat or speak up, if that's okay.
I'll relay what I can see.
Thank you, Sophie. Any response at all?
Not yet, so I think we'll just go through.
Okay, so this is, you'll get a call from radiology, say, why did you request it, and not stating which side of pain, hip pain, are they experiencing. So this is not a good example. So what you should do is 75 years old female, admitted with a fall, x-rays show no abnormality, however increasing left hip pain, she's unable to mobilize, query neck or femur fracture. So you telling exactly clearly the patient came in, x-ray didn't show anything, but they're still having pain despite having a normal x-ray. Now, are we missing anything? Has she got any fracture? Okay. Next one. CT head request. 80 years old male, admitted with a fall, CT had to rule out intracranial hemorrhage. Again, this is not a good example, a good way to request. So what we want to do, 80 male admitted with new onset confusion after a fall, patient currently on warfarin, so it's a blood thinner. So we need CT head to rule out any acute intracranial pathology such as bleed in the brain, which can cause confusion. And it is according to NICE guideline that they need to have a CT head. Okay. So if you don't really specify the reason of the request,
we've had another question, so that
perfect.
The chat was disabled there, so that the guys have been putting some questions in the Q&A.
Okay.
Someone's just said, but what if it was an emergency situation and in a hurry? So there might have been a few details that were missed unintentionally. So I don't know if you want to answer that, Katie. So
in an emergency situation, you will it's really common to miss information out, but if it's emergency, you'll have to call the radiologist and say this is an urgent scan. So say MET call, medical emergency call. If I attended MET call and this patient needs a scan, I'll request on the computer, then I'll call them and say, hi, I've just attended the MET call. I've requested a scan for this patient. Could you do this urgent scan for me? And they will then read the scan, read your request, and then they'll ask more information if needed. Hope that answers your question.
Thank you.
Yeah, so so if someone's asked you to order a scan, so as a junior doctor, it's very common for your senior regis or consultant to just order a scan, okay? But if you don't know why they want you to order a scan, and then radiologists question you or say they don't need a scan, they've had this before, or they don't have these symptoms, they don't qualify for this scan, you need to be able to tell them what exactly you're looking for. So it's important for you to understand why you're requesting, not just request it for the sake of requesting and not knowing what to do. So it's always a good practice to know why you're ordering it. Okay. And if you're not sure, ask your senior and colleagues. Again, if it is urgent, always call the radiologist. Don't leave it and then delay patient, discharge, or it'll get delayed another day. So always make sure you request with full details so that scan doesn't get rejected. Okay. Sophie, do you have anything to add on radiology requests?
So just to be really clear, so the radiologist is the doctor who works within the radiology department. So they will vet your scans, look at them, make sure they're appropriate, and then they'll also interpret the scans. A radiographer is not a doctor, but they can help vet scans and interpret some scans. Also, so why do we need to do this? Why can't everyone just have loads of scans? And the answer to that is radiation and money. So we don't want to be subjecting patients to unnecessary amounts of radiation. So sometimes when you have that conversation with the radiologist, they'll say, well, this scan might be more appropriate for this patient. Maybe you can see what you're looking for more easily on a certain type of scan, or maybe the scan's less radiation, so less risk of harm to the patient. So just a few other things to consider. So there's lots of things that you go through your mind as you're requesting the scans, but the radiologist should be there to help you to make that best decision for the patient.
Yeah. So next we'll go through on-call cases. So these are the very, very common cases that you'll see as a junior doctor. So hopefully you'll find it helpful. So you've been asked to review a 60 years old lady who's had a new onset temperature of 38.5, and she's been coughing and reported feeling tired. So as a junior doctor, you'll do lots of phone calls and you'll be called to review lots of patients. And the system that we were taught to use in any patient's review is A2E approach, which is very easy, mnemonic A, B, C, D, E, and then you follow that mnemonics. And then by the end of the examination, then you'll have a good idea of what's wrong with this patient. So A is airway. So if the patient breathing normally, do they need any airway support? So if you find a problem in each stage, you don't move on to the next stage, you treat that there. So say if the patient is snoring, like there's an airway obstruction, or they're not, they're having difficulty in breathing, they're not maintaining their own airway, then you'll give oxygen. Okay, and then you'll move on to breathing. So in this case, she's maintaining her own airway, so I'm happy with airway, then I'll move on to breathing. So in breathing, you do respiratory rate, which is 20, for this case, she's 26, which is high. So normal is 16 to 20, I would say, but 26 is high. Oxygen SpO2 mean oxygen saturation, which is 94 and above is normal. She's got 92% on air, so this is low. On chest examination, she's got some crackles in her left lower base of the lung. So you'll listen to chest, all areas, and then there's the left lower base, there's some crackles. So in this breathing, I'm not happy, so I won't move on to C. So I'll start with oxygen sat. SpO2 is 92, so I want to give her oxygen to help with the oxygen saturation. Okay, and then circulation, her blood pressure is 85/55. Again, that's very low. Normal is 120/80, and heart rate is high as well, 124, and she's quite warm to touch. So in that stage, in C, I would then put a cannula, which is a small needle that you give fluids and medications through the patient's vein. So put a cannula, take some bloods from that cannula, and then give some fluids to hopefully boost her blood pressure up. So her blood pressure is really low at the moment. Okay. D is for disability, or sometimes people say diabetes as well. So D, you check glucose. Some people can present like with low consciousness level when they have very low glucose, if they have hypoglycemia, which means low glucose. So her glucose is 8, which is normal, fine. GCS mean Glasgow Coma Score, which is her alertness. So it's 15 out of 15. Pearl mean pupils equal and reactive to light. That's what the normal examination. If the pupils are not equal or they're not reactive to light, we'll be worried about something in the brain or a bleed. Her temperature is 38.5. So it's 36.5 is your normal temperature. So 38.5 is quite high. So on overall, after you've done D, you do everything else examination. So you check for abdomen, check the legs, rash, any bleeding anywhere. Okay, so overall, what do you think is the differential diagnosis? So if you've been asked to see this patient on your on-call shift, would you be worried? And if you're worried, then what's the differential diagnosis? Which means, like, what do you think is wrong with this patient?
So someone's put, does she have chronic bronchitis?
She's normally fit and well.
So just to be clear, so chronic is like a long-term condition.
Yeah.
This is what we would call acute. So this is where someone's become sick quite quickly. So someone else has put pulmonary edema.
Could be pulmonary edema. So I'm guessing you think it's pulmonary edema because difficulty breathing, oxygen sat's quite low. Yeah, but it doesn't necessarily give you temperature. It's not common for pulmonary edema to give temperature, but it can be. I would agree that it's one of the top differential diagnoses. Yeah.
So what's going to give you a fever? That's the big clue.
Yeah, that's the clue. She's warm to touch, she's coughing, and she's got temperature.
Pneumonia?
Could be pneumonia, yeah. So chest infection, yes. So in this case, this patient has sepsis. So sepsis is just a, umbrella term for infection in your blood, and that could be from your chest or urine, or the source of infection can be from anywhere else, but you've got infection in your blood. So I don't know if you have heard of sepsis 6, which is you give 3 and you take 3. So what do you give? You give oxygen to keep the saturation above 94%. You give IV antibiotics and you give fluids. You take bloods and blood culture. So I hope you can see the blood culture bottle on the picture. So blue and the purple bottle. And you measure the lactate. So if you look down, directly down from the lactate blood culture bottle, this is the blood gas to measure the lactate. And this is urine output. So you put a catheter or you measure the urine output. So this is a sepsis 6. As a junior doctor, you'll be expected to, review these patients and give treatment and stabilize sepsis patient. Then you will get a senior review after. At least you are expected to do this sepsis 6 treatments and investigation yourself independently. Okay. Any questions at all?
I can't see anything coming through just yet.
Okay. So SBAR, which is useful in referrals. So you've been asked to review that sick patient. You think she's got sepsis. So you've done sepsis 6, which give 3 and take 3. After that, what you need to do is to get your senior input. So SBAR is a very, very common and useful tool that we use in hospital to refer a patient. It's just, it's very easy to follow. So situation. So first you introduce, hello, my name is Katie. I'm one of the doctor calling from hematology ward. Who am I speaking to? Is this a reg? I would like to get advice on one of my patients who's very unwell and news of 10. Then you're telling that you're really worried about this patient and this patient is very unwell. So then the other person at the other end of the phone will be listening more carefully, and they know by saying you've got news of 10, they know the patient's very unstable. Okay, so background, this patient presented with a 4, and it's got background, his past medical history of so-and-so. It's now presented with the new cough and temperature. I've done A to E assessment, and this is my findings. and then you can just say what you found. I've started her on IV fluids, IV antibiotics. I've requested all the bloods. I would appreciate if you could come and review this lady. So just a very, very neat way to refer a patient. Any questions at all? I can see some questions on the question and answer. I can't open it, sorry.
No, it's fine. I'm just typing them as we go through.
Okay, perfect. Thank you. So that is the S-bar that you should be familiar with when you refer a patient. Anything to add at all, Sophie?
No, I suppose we could just link it back to communication again, like, can't we? It's a tool that we use to aid our communication. So when a patient's really sick, so like this patient's likely got some overwhelming infection leading to sepsis. We need to treat them urgently within an hour, giving the 3 and taking the 3 things that you mentioned. And then we need some help. And what we don't want to do is go through and talk all about the patient, what pets they have, who the brother is, what school they went to, all that. We've got to be really concise in our communication, haven't we? And this helps to do that well, to make sure we're all on the same page.
Yeah. So just to summarize on referrals, so in urgent cases, it's always important to refer on phone. So sometimes some of the referral system in hospital are online systems. So you send an email or you send a note to another specialty and you wait for it. But if you are really worried about this patient, it's better to call them and speak to them on phone than using online, that it can get missed. If you've done the job, say you've been asked to refer a patient to certain specialty, if you've done it, always document and who you spoke to on phone. So like, I've talked to orthopedic registrar, so-and-so, and the plan is as follow. Thank you for the advice. So next doctor who look after this patient know exactly what's happening. Okay, after you've gone home or you finish the shift, if you don't document, then no one knows, and then they'll have to do that referral again. The other person on the other specialty might get annoyed because they kept getting calls from the same patient. It's just a waste of time for everyone. Clarify with the specialty who is responsible. So sometimes if the patient has multiple comorbidities, so patient has different problem going on at the same time, some of the specialty just come in, they tell their plan and then left it. No one knows who's are we doing, because the patient is in respiratory ward, but then this patient also had a fall, so she's now under orthopedic. So orthopedic doctor might come over and then write in their plan, MRI here, blah, blah, blah. And then the respiratory doctor might think, oh, orthopedic doctor would do MRI request. I don't need to do it because it's not my job. There's no communication. So you need to make sure that there's a good communication between different multidisciplinary team to make sure who's doing which job to avoid the delay, okay? Say sometime if the referral is not accepted, then just kindly ask, can I just ask why? Then you can learn from it, or you can communicate with the different team that's needed. So especially that happens in Max Fax or plastics team. Sometimes they say, this is not my specialty, you should call the other team. Then there's a bit of, confusion. So always ask and communicate with your seniors as well. Yeah, that's all about referrals. Sophie?
Yeah, fine.
Yeah.
Let's move on to the next case then.
Yeah. So Sophie's now going to do her case 2.
Yeah. Okay, so You're the F1 on call, so remember that's the junior doctor in the very first year after qualifying. So you're going to be carrying the cardiac arrest bleep. So what that means is when you're in the hospital, if someone goes into cardiac arrest, so they stop breathing, the heart stops beating, obviously that's a massive emergency. So you hold a special bleep, which I bet some people don't even know what a bleep is. It's like a pager. So this small machine will go off and tell you that there's a cardiac arrest, so a really big emergency's happened with the patient. So you're the F1, you've been called to a cardiac arrest on ward 14A. So looking at that S-bar handover a little bit further, so this bleep would go off and you would be running or walking very briskly to this location. But what you might find is as you walk in, there might be someone who calls you, you might be able to get a little bit more information. But if you hear the cardiac arrest bleep, you go to wherever is needed urgently. But for the case here, so the situation is a 56-year-old man who's in cardiac arrest. He's been on the orthopaedic ward. We've got a very orthopaedic theme running through.
Yeah.
There are other wards. So he was in bed with a femoral fracture. So that means he's broken that thigh bone, the big long bone in the leg, after falling off his motorbike. So at the minute, the assessment is he's not responsive, he's got no pulse, he's not breathing. So we're currently undertaking CPR. So this is the people on the ward telling you this. So whoever's looking after him, so it might be the healthcare assistants might be there, the nurses might be there, maybe the physio was seeing him at the time. Everybody looking after that patient should know how to initiate CPR and be trained and up to date. So the recommendation would be you already on your way. You need to be coming over there as an emergency. So can you move the slide across there? Okay, so we'll do one at a time. So as you're running over, so the F1 running across, what you might find in the corridor, or hopefully it will already be with the patient, is the emergency trolley. So it's usually a red trolley like this with lots of drawers. And this is going to have all of your emergency medication, different things you're going to need to help to look after the patient. So this would also be relevant for the case one, the first patient we saw, and this would have lots of the equipment that would help you to treat the patient. Now, the thing is here, obviously, we're going to look at, I'll talk through lots of different equipment, but it's not going to be just you doing this. You're going to have different colleagues and different people to help you. But particularly as the F1, you might be grabbing things out of the trolley. You need to know where it is and using some of that equipment. So we should be all trained basically in how to use it. So if you look in the top drawer, so as Katie mentioned before, the first thing we assess when a patient's really sick is airway. So we might need, for this patient, we're going to be giving him some rescue breath. So we're going to be popping a mask on his face and we're going to be pumping that mask. So that's the bag valve mask. We might need to put an airway into him because we're not going to otherwise be getting that air inside. So there's a few different mechanisms that we can use for that. We might need to use some suction. Sometimes there can be some vomit, some secretions around the mouth. So you can see that there. And then a few other things, a bit funny, but skin prep razors. So if someone's really hairy, you might need to get rid of some hair. And scissors is always helpful to cut different areas. Think if this patient might be fully dressed, and actually if we need to get at the chest, we might need to actually cut clothes and things like that. So that's what you might see in the top drawer. So if you press to the next slide, okay, so then the second drawer, so we're still talking about this red kind of trolley. This has got more advanced airway equipment in that we might need to use. So you can see there, eye gel is a type of airway that we just put down into the patient to help them breathe, and we'd attach it to oxygen. There's a laryngoscope, so that's a piece of equipment that helps you look down inside kind of the patient's mouth to put tubes in if we need it. Obviously, as an F1, you wouldn't be doing this unsupervised. There would be someone there to help you. You can also see that there's a McGill forceps. So sometimes if a patient might be choking, so obviously this trolley can be used for all sorts of different things. The patient might be choking and we might need to remove something from the throat or something like that. So let's look at the next drawer that we would see inside. Yes, this is our IV access. So Katie mentioned earlier the patient that she saw. Obviously, we needed to put a cannula in. So they're the different colours you can see running along the bottom. And the different colours just mean different sizes. So when someone's really sick, you want to put one with a wider lumen, a wider circumference, so we can get drugs into a patient really quickly if we need to. What else? Needles, again, taking bloods, things like that. Safe disposal, even though it's a huge emergency, we've got to be really careful with sharps equipment, things like that. So we've got all of that there. And can you see the way that the trolley's running? It's A to E, as Katie mentioned for her assessment. Okay, so let's look at the next draw. Okay, so going back to our patient's in cardiac arrest, so they're not breathing and the heart's not beating appropriately. So what we might need to do at some point is give them some drugs to help to restart the heart. So something like adrenaline, amiodarone is a couple there that you would see in that trolley. So just think they're on hand immediately to get them as you required. Okay, so fluids also might need them. So remember, Katie's patient had very low blood pressure, so that's relevant, and that you would find that in the trolley. A different patient might have anaphylaxis, so a huge allergic reaction, so we'd have that in our trolley as well. If we click on to the next one, Katie.
Yeah.
Bottom drawer, so a few miscellaneous things. So there's going to be some information to help you deal with emergencies. So some flow charts that we can look at, waste bags, face visor to help protect yourself, gloves. You might want to do an ECG, so looking at the electrical activity of the heart. We might need to put a tube down a patient's throat, nose to get some vomit away. There's all sorts of things, but that should have everything you need. And if you just click one more time, the thing that's going to be really useful for this patient is going to be our defibrillator. So remember, not breathing, heart's not working properly. We might need to shock them. Okay, so if we just move to the next slide. Okay, so this is a team of people who are looking after the patient. So all different people, as I said, you're the F1, you won't hopefully be there by yourself. You might be for the first few minutes, but then someone should be able to come and help you. So this shows all the different people that will be working within that team. So you can see the girl kind of at the front right with what looks like an iPad. She's going to be probably the hands-off person, the person who's overseeing the whole situation. So someone might be giving chest compressions, someone you can see is holding the bag valve mask, so giving air, oxygen to the patient. Other people are doing different assessments. Someone might be putting the cannula in. So all sorts of different things are going on there. And what the person with the iPad, so if you just click on the next slide, what that girl with the iPad there would be doing when she's in charge, she would be making sure that everything was happening in the correct order and we were doing all the treatment we needed to for the patient. So this is just a little algorithm that we use to help us. So obviously we said this patient was unresponsive, no heart rate, no breathing. So we're going to do CPR. So we're going to do chest compressions, 30 compressions to 2 breaths with that the mask on the patient, okay, and the oxygen turned on. And then we're doing an ECG all the time and we look at the rhythm, okay, so how the patient's heart is beating. Is it quivering? Is it moving really fast? What is it doing? And depending on what the heart is doing, we can then give shocks or not give shocks depending on the rhythm. And then through all of that as well, we'd be giving some different drugs out of our trolley to help to try and get the patient's heart beating in an orderly way. Okay, so if we move on, because I'm just aware of time.
Yeah.
Okay, so unfortunately, after multiple rounds of CPR, the consultant decided to call the patient's time of death. So we've decided as a team with the consultant leading that actually there's nothing else we can do. We've tried lots of different treatments to try and help the patient. So unfortunately, the patient's died. So as the F1, you must go with your senior colleague to break the bad news to the patient's family. Okay, so if we move along. Okay, so how do we do this? Now, this is hard, and medical students, junior doctors find this really, really difficult and uncomfortable, which of course it is, it's horrible. But what we can do is there's a way that we can structure this in order to try and make it the most the best experience we can for the patient's family, because this is obviously going to be something that they remember for the rest of their lives. This is a huge event that's happened here. So what we need to do is, obviously we're keeping the family on board up to date all the time. We need to know what they know, what we know, make sure that our knowledge is matching. What treatment did we give the patient? Obviously this patient's died, so there wouldn't be a planned discharge date for them, but when we actually will be breaking the bad news, we need to make sure we've got the appropriate environment, so somewhere, a room where we're not going to be disturbed. Make sure your bleep, your phone's turned off. What does the patient's family know already? What would they like to know? So how much information do they want to know? You've got to be really kind of honest, open, not use really difficult medical jargon. We always say you've got to say that the patient's died, not that they've passed away. There can be a lot of confusion about what that means. And then obviously the family, the friends are going to be very upset. So we need to, to empathise with them, provide support, signposts to the different support that would be available, and then tell them what the plan is going forward. So can they go and see their relative who's unfortunately just died? What would they like to do in terms of, where does the patient go next? What's going to happen? Is there any particular items they might want to bring in for the patient? All sorts of different things. And the little kind of like help there is, you can see in the red, it's spikes, and that's how we prepare and help to help us to deliver that bad news in a really professional way, and a way that can be the most helpful and informative for the family. Okay, so back to Katie now, I think.
Great. Thank you, Sophie. That's really, really helpful. Do we have any questions in the chat box?
Let's have a look. So nothing else. There's one remaining that we'll ask at the end that's quite specific, but nothing else at the moment.
Okay, so this is the final bit where we'll just give you a few top tips. So positive work environment is very important. Essentially, you'll be staying in this ward for for 4 months, 9 to 5. You'll be seeing these colleagues every day. So always be helpful, support each other, and be respectful. Then, it will make your work environment a bit more pleasant, and you'll enjoy your foundation training. So treat everyone with respect and nice to people, so they will also help you out. So when I started F1, I always, go and introduce nurses or HCA, whoever's, and, just ask them, I'm an F1, I don't know where things are, or I'm not sure how to do this. And they're nurses who are more knowledgeable sometimes. They've been there for a long time, so they're really, really, helpful. And they know you're a new doctor, new junior doctor. And if you get on with them, they'll make your life a lot easier. So look after yourself and know your limits. So when I did my first ever on-call, long day shift, so 8 to 8:30, I didn't eat or drink, and I was just really, 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 I just got burnt out by the end of the day. And it's just, I learned the lesson. I was like, no, you need to have your own breaks. And if that's 15 minutes or half an hour, you should have your breaks. You need to look after yourself first to look after others. So always, always make sure to look after yourself. So yeah, and if you're struggling, say if you find yourself leaving work late every time, then is there anything that other like education or supervisor or your consultant in the ward can support you? Thankfully, I haven't been in that situation, but I know some people who were in that situation, and they can get burned out. And so make sure you exceptional report, which is a system that you report with your login. Say, I should finish my shift at 5, but today, because of the sick patient, I was dealing with the sick patient, I finish at 6. Then they should either give you that 1 hour back. So say rota coordinator might say, okay, we've got enough staff on this day, you can have your 1 hour back, or they can compensate you with the hourly rate. Okay. Sophie, any tips from you at all?
I think you've covered it quite well, to be honest. I'm quite just a little bit conscious of time because it is just after 5, so it might be worth us leaving it there, but then opening the floor to questions, and if anybody needs to leave, then that's absolutely fine. One of the questions we've got through, so I think it was off the back of my kind of breaking bad news section. So how do we handle patients that have extreme outbursts? So outbursts, like maybe thinking about after hearing bad news, even though you think you've done the best job you can, what do you think?
I mean, I think everyone react differently. So sometimes they get angry, or they cannot accept the fact that their loved ones are suffering or have died. Then I guess you just have to give them a bit of space, offer them the support they need. So I'm really sorry, you know, is there anything I could do? Or just support with empathy, really.
And then I think with that is really important, as you mentioned, to look after yourself. So when, you know, you've had that horrible bad news that you've had to deliver, obviously that's going to affect you being the doctor, being the healthcare provider. So you need to have some sort of debrief and reflection within yourself. So, you know, as the question was, that, you know, you think you've delivered that well, but is there anything maybe that was misunderstood? Why is the patient the patient's family behaved in the way that they have? Could you change anything? Or actually, did you just do everything right? And sometimes, as you said, people do act and behave in a certain way, and that's just part of a grief response. But I think what's really important there is to look after yourself, to reflect upon the event yourself and what's happened, and then if you need that, access that support of other colleagues, of senior colleagues, in order to debrief and talk about things, and that helps then to reduce the risk of burnout.
Yeah, what I would advise is to always listen to how your seniors break bad news. And I've seen really good consultants doing a really good way of breaking bad news. And you pick up a few things from each seniors, and then, you know, you start to make your own way of breaking bad news.
Yeah. So then another question is, what do the working hours of a junior doctor look like?
Oh gosh, it depends on the specialty, I guess. So if you're in a supernumerary, which means you have that specialty has no on-call, so you purely 9 to 5. So supernumerary as an F1 would be, what did I do supernumerary?
Before 40 hours, wouldn't it?
Yeah,
I've done. So
I think surgery is supernumerary.
It depends where.
Yeah.
It
ophthalmology for me when I did F2 was supernumerary, so no on-call.
Yeah, so I think if you have no on-call commitments, it's 40 hours, and then with on-call commitments, I think it's about 46 hours is the general week. But obviously it's not the same every week. Sometimes it's slightly less, sometimes it's more. There is the European directive of working hours, of how much you can actually legally work, that should be adhered to. And also there is the option, if you fit certain criteria, to work less than full time, if that's something that would suit you better. But I think the answer is it's quite variable depending on the job that you've got and the hospital that you work in. Okay, so another question. So if the patient's death was due to a minor mistake that could have happened, do we admit this to the patient's family? If yes, how would you phrase this?
You should absolutely admit it if it's the case. It's a duty of candor. So I think I've only seen it happen once in a COVID ward, and this patient had, I think, primary lung cancer, and they missed it in the first chest x-ray or CT scan, and then he came in after a few years, and obviously the cancer has grown. So what my consultant did was, you know, he explained to the patient, He said, we found this is cancer. We found we compare it to the scan that was done 2 years ago, and we missed it, and really apologize for that. This is the treatment option going forward. Are you happy with it? If you want to talk more about it or complain about it, this is the leaflet to do so. So he was very, very clear that, you know, they've made a mistake. This is the plan forward. And if you're not happy, this is the complaint procedure. Yeah. So very, very open and honest about what happened. I think that's really important.
Yeah, I agree. And as you said, I think the key word there is that duty of candor, isn't it? Perfect. Okay, so there was a question that we got right at the beginning. So one of the people, so I'm currently completing a postgraduate degree in information technology. Would my background in GRA be used for admissions? I'm also a non-traditional student with 15 years of work experience within healthcare IT systems. So I don't know what you think particularly there, Katie.
So that is more information. What is GIT?
GRA. So I think basically for that question, you need to look at the specific admissions criteria for whichever universities you're looking at, because I'm not sure if I didn't apply postgraduate, but I'm not sure if it has to be a certain type of degree that they want if you're going to apply postgraduate, but you could also apply undergraduate and not use the degree. So I think that's something that you would have to look into.